radiation for brain metastasis since 2021. 24 patients with 39 metastases received stereotactic radiosurgery for brain metastases last year. And we also employ whole brain irradiation.
Recording in progress.
Do you hear me?
Yes, we can hear
So
you.
the whole brain irradiation with hippocampal avoidance. And now my colleague, Roman, will introduce our experience of radiotherapy for brain metastasis.
Good afternoon, colleagues. Good afternoon, colleagues. I would like to introduce our presentation on the following topic: radiation therapy for brain metastasis. Brain metastasis may develop in up to 14% for patients with cancer. This metastasis can have a significant impact on patient survival, as they can cause the detrimental effect of neurologic function and neurologic symptoms. They can also contribute to reduction in overall survival. Treatment options for brain metastasis include whole brain radiation therapy, stereotactic radiotherapy, and systematic surveillance. This treatment option may be considered alone or in combination. Progression of intracranial metastasis can lead to neurologic morbidity and death. Whole brain radiotherapy remains the standard of care for decades, but the development of SRS allowed treatment of limited brain metastasis alone, often in a single fraction, while larger spreading surrounding brain. After numerous studies have been identified indication for SRS. The amount is less than equal to 10, size is less than equal to 14 millimeters. The total volume of metastasis should not reach 15 cubic centimeters. Karnofsky index is from 17 to 100. For patients with a favorable prognosis who have brain metastasis that are ineligible for surgical resection and SRS, hippocampus avoidance during whole brain radiotherapy is recommended as a primary treatment. Hippocampus sparing is not recommended because where metastases are located near hippocampus and or in case of leptomeningeal metastasis. The use of MRI is an important part of CT simulation. MRI data allow for a clear visualization of the tumors. Stereotactic radiotherapy is a highly effective approach and represents the current standard of treatment for patients with limited number of brain metastases. Given the size of the tumors, treatment could be done in one or more fractions. SRS can also be used to brainstem metastasis. The most common complication for SRS is radionecrosis, which occurs in 5–15% of patients. This late side effect can be associated with neurological deficit and significant neurological morbidity. It is important to exceed certain limits of brain volume to reduce the risk of radiation necrosis when planning treatment. Whole brain radiotherapy is a standard treatment for most patients with brain metastasis. However, after such treatment, approximately 10% of patients may develop radiation-induced brain damage, which can lead to cognitive impairment. To reduce the risk of this, it is important to limit the radiation dose to the hippocampus to less than 9 gray. This slide shows dose limits for critical structure dependent on the different amount of fractions. Let me to present you our critical cases for the treatment brain metastasis. 75 years old patient with lung cancer received a course of sequential chemoradiotherapy treatment. The result of treatment was stabilization. After 5 months of treatment, we found out MRI sign of brain metastasis in the left frontal lobe, in the right parietal lobe, in the left parietal lobe, in the right hemisphere of cerebellum. Methods of treatment is SRS remat up to total dose 27 gray per 3 fraction. When calculating the radiation therapy plan, we observe recommended radiation dose for the critical structure, V20 brain volume, with the exception of brain stem Dmax, which was due to irradiated volume and metastasis localization. According to the result of the patient MRI after 1 month of treatment, patient has post-radiation change and reducing the size of brain metastasis. The patient is currently alive and receives atezolizumab immunotherapy. On this slide, you can see the second case. 16-year-old patient with breast cancer received the complex treatment in 2015. The result of treatment was stabilization. In 2023, was found out lung brain metastasis. By MRI sign of brain metastasis, multifocal metastasis in the frontal, parietal, temporal lobes of the brain, the amount of metastasis were more than 11. The maximum size of metastasis was 30 millimeters. Method of the treatment was hippocampus avoidance whole brain radiation therapy plus SIB. Methods are IMRT. Whole brain, the interior volume of the brain was irradiated at dose of 30 gray per 10 fraction. SIB. 7 metastases larger than 1 centimeter were selected for irradiation, which were irradiated at dose for 40 grays per 10 fraction. We observe recommended radiation dose of hippocampus and other critical structure. So, thank you.
Clinical goals. The clinical goals. Clinical goals. Here are the clinical goals of the last case.
We observe recommendation radiated therapy dose for hippocampus and other critical structures.
Thank you. Thank you, dear colleagues. That's all. Our experience is not too large, and we follow up for patients received whole brain irradiation and stereotactic radiosurgery, and later we can get more information about them. Thank you for your attention. Do you have any questions?
Yeah, thank you for your presentation and also the 2 cases. So, Dr. Sun, are you online? And Dr. Mai and our radiation oncologist, do you have any comments or any question for the presentation and also cases from San Mr. Box team or not? Do you have any comments, Dr. Sun? Are you online now, Dr. Sun?
I would like to suggest you to follow and to continue, and at the end of your presentation, we'll discuss the questions if you have them.
Yeah, but try to ask something after the presentation in order to have the hot topic to discuss later on. So I asked the question to our staff here. Các anh chị có thắc mắc, có hỏi ý kiến gì không ạ? Xin bác sĩ chị Xuân ơi, chị Xuân có hỏi gì về cái phần trình bày của họ cũng như là các cái ca lâm sàng không ạ, để chúng ta biết để chúng ta tiếp tục.
Chắc để mai trình bày xong đi rồi.
Okay. So we could like to.
Dr. Khan?
Yeah.
I'm sorry, I can see the question in the chat of the conference from Dr. Nguyen. So this is regarding the size of the tumor for the radiotherapy. May I ask this question to our colleagues?
Yes.
Татьяна Михайловна, там в чате есть вопрос, и доктор спрашивает, есть ли какой-то...
Yes, of course. The total volume of metastasis less than 12 centimeters, and the greatest diameter of is 4 centimeters. And besides the constraints that are available are used, and we make the decision of the single dose and the fractionation while the dosimetry planning with medical physicists. I suggest you to continue, and maybe at the end we'll discuss another questions.
Yeah. We think that we will present our talk first, and after that we will make the discussions then. Now, so I could like to introduce Dr. Phương Mai from Radiation Oncology Department number 4, and also Dr. Trần Thị Xuân is the vice head of the Radiation Oncology Department number 1, not number 4. I'm sorry. So they will have the presentation on stereotactic radiosurgery for brain met. So please, Dr. Nguyễn Anh, Phương Mai, and Dr. Xuân.
Okay. Good afternoon, everyone, and my name is Phương Mai, and I'm an oncologist at Ho Chi Minh Oncology Hospital. And today I will present to you the stereotactic radiosurgery for brain metastasis at our hospital. The content of my presentation today include 6-part overview about us, indication, protocol, experience, and clinical case. About the brain metastasis overview, as the doctor has talked before, and I can go through this slide. About us, we have a 3D big board CT simulator, 4 variant linear accelerator, 5 electron linear accelerator, and 1 trilogy, 2 true beam, which can do 3D IMRT VMAT, and 1 true beam can do 3D IMRT VMAT and HyperApp. And our team includes oncologists, physicists, and radiation therapists. And we have been training with the professor about SRS technique. And this is about our history of treatment for the brain metastasis before. Okay. Before 2019, all the patients have a brain metastasis have treated with the whole brain radiation by 2D or 3D CRT technique, and we just use the KV for IGRT before treatment. From 2019, when we have a two true beam machine, the patient have brain metastasis was treated with SRS whole brain radiation with boost whole brain radiation with hippocampus avoidance, and we use the 3D CRT or VMAP technique. And we have a KV, MV, and CBCT for IGRT before treatment. And from 2023, we have more option for the patient. That is a HyperAct for the SRS technique. And this is our protocol indication for the patient have brain metastasis. With the patient non-surgery and with the patient after surgery, the tumor size must be smaller than 4 centimeters in diameter, and the number of tumor is smaller than 4 lesions. The KPS of the patient have been 80 to 100, ECOG smaller than 2 and shear 5 to 10. And DSGPA have been than 6 months. For the patient brain metastasis non-surgery, we can treat. They can be treated with a single fraction or 3 to 5 fraction. It depends on the size of the tumor and the number of the tumor. This is the index we use for elevate the patient before we have the decision for SRS, the GPA index or SIR. Yeah, you can see on the slide. And next, and now our protocol. All the patients with the brain metastasis have diagnosed with brain MRI with contrast, and then they if they have indication of SRS, they have been they will have the simulation, the hair cut under 1 centimeter, and they have take the dermoplastic mask or fibroblast mask. After that, we take a CT scan simulation non-contrast with a slide 0.6 to 25 millimeter and not in the tablet. Then we take the contour. We contour the tumor on the brain MRI, and the brain MRI should be taken before simulation 1 to 2 weeks, and the best is in the same day we have the simulation, and we accept the maximum is in 1 month. Then we fusion the MRI and the CT simulation, and then we control the GTV on MRI 3D pan sequence. And the BTV is a GTV plus 2 millimeter. And if the patient have surgery before, the BTV is CTV surgery cavity plus 2 millimeter. This is the image about our simulation at our hospital. We use the dermoplastic mask of the Cisco and the fibroblast mask on compass when we do the HyperAct technique. And this is our CT simulation, and the CT slide 0.6 25 millimeter and include the frame of the mask if we use the HyperAct technique. Sorry. Here, sorry. Yes. Em một cái con chuột nó có gì mà chứ nó giật. Sorry. Okay. Nó vẫn tại vì nó cứ ở trên mà nó không có. Sorry, we. Dạ, cái con trỏ. Okay. Yeah. Okay, we continue. We continue. You can see the frame of the mask here. This is the image of our contouring of one our patient, the tumor on the MRI, and this is a CT simulation. Next. After we contour the GTV and BTV on the CT simulation, our physicists will planning on ellipse and with the technique VMAT or HyperArc. And the oncologist will evaluate the plan. The BTV have the mean bigger than 98%, and the mass have been smaller than 140%, and the organ at risk will those contrast. We will follow the TG101 and contact. And the QA, we will have the QA before the treatment day and one QA right before the treatment if we use the HyperArc technique. Okay. And we begin a treatment for the patient within a week of the simulation, setting a patient, and we will take the KV, CBCT before the treatment, and then MV before each non-columnar act, and CBCT after the treatment. And if we use the HyperArc technique, we will use the OSMS during the treatment. And the setup and draw of at our hospital, you can see in this table. Okay, next. This is some photo about our treatment for a patient at our hospital, the positioning, the treatment, and this is the KV before the KV and CBCT before the treatment. And we use OSMS during the treatment if we use the open face mask. Next. After the treatment, the patient have been followed up 1 week. After SRS 1 week and 1 month, the patient will be take a clinical examination about the neurological symptom. And we can control the symptom of neurological by dexamethasone or mannitol, etc. And after 3 months in 1 year, or when the patient have the symptom of neurological, we can take the MRI. And after treatment every 6 months, or when the patient have the symptom, we will brain MRI. So, I will introduce about our experience of SRS. We begin do this technique from August 2019 to April 2024 in 56 months. We have treated 66 patients, and there are 4 patients have SRS 2 times. And we have 40 cases with the VMAT technique and 16 cases with the HyperArc. In 2019 to 2020, at the beginning of this technique, we have 14 patients, and in 2021 we have 12 patients, and in 2022 we have 16 patients, and in 2024 we begin doing the HyperArc technique, and we have 13 patients, and in 2024, we have 10 patients and 8 patients have SRS with the hybrid technique. And in 66 patients, the lung cancer is the most disease have the brain metastasis with the 45%. And the second one is the breast, and then the esophagus, and one case is pancreatic. So we continue with the clinical case. I will introduce the 2 cases of we have treated with the SRS. The first case is a lung cancer. We have treated with surgery and chemotherapy, and then he has recurrent in brain metastasis, and he have SRS 2 times with the BMAT technique. And the second case is the female patient who have the breast cancer, and she has treated with surgery, chemotherapy, radiation, and then recurrent in lung, liver, bone, and metastasis. And she has been treated with SRS and hyperactivity. About the first case, the patient, 54 years old, no medical history and no history. He was diagnosed in February 2019, non-small cell lung cancer, 4 and 0 and 0, adenocarcinoma RAC2 and EGFR negative. He has been treated with right upper lobectomy and then chemotherapy with navambin cisplatin 6 cycle, and in March 2019. And he was followed up 6 months. Then in August 2019, he has a mild hemorrhage, a KBS to 90 to 100, and he has 3 lesions in brain MRI, and the GPA is 26.5 months. At that time, you can see this is 3 lesions on the MRI, and we have to choose SRS for this patient. The patient with simulation, and this is a 3 lesion after we contour on a CT simulation. And because of the lesion is too small, so we choose the BTV is GTV plus 3 millimeter. And the patient was treated with the dose is 30 gray with 5 fraction from the 19 August to 23 August 2019 with the VMAT technique, and our physicists take the plan with the 4x and no couch table view. The max of the plan is 28.9 gray, about 129%, and the minimum is 28.6 gray, about 95.6%. So you can see here the dose of the BTV, 100% dose cover 100% volume of BTV, and we accept the brand outside BTV. V20 is 21.5 cc, and the brainstem Dmax 0.4 right, and the spinal cord Dmax 10065 right. After next, after the patient has had the treatment, he has been followed up 1 week and 1 month, and we take the brain MRI after the treatment 2 months. And you can easily see here the 3 lesion is smaller than diagnosed time, and but it had it have a small problem that there was a small lesion, new lesion in left parietal lobe. But at that time, after the treatment, the first treatment 2 months, we choose to follow up this lesion in 3 months. After 3 months, we can see the lesion is bigger from here to here, and one lesion 25 millimeter. And at that time, we have many choices for this patient: surgery, SRS, or whole brain radiation. But at that time, the patient have KBS 90 to 100%. She is sick and no neurological symptom and the systemic disease control. So we choose the SRS as second time. And the second time, the patient was treated with the 25.5 gray per 3 fraction from the 19 February to 21 February 2020. And at that time, we used the PTV is GTV plus 2 millimeter. And the GTV has the volume is 9.98 cc and the PTV is 16.4 cc. And our physicists take the plan with with 5 arc and 3 arc non-coplanar. And D max is 32.8 rate, about 129%, and the mean is 24.7 rate, about 97%, and the normal brain the 7 cc is 20.7 rate, smaller than 23.1 grade, and the 20.9 cc is 13 grade, smaller than 21 grade. And the patient, after the treatment, the patient continue follow up. We can easily see here, we take the brain MRI every 6 months. On May 2020, the lesion of the first treatment is smaller and very small. And the lesion of the second time is smaller through the time. You can see the change through the time. Until now, in March 2024, the lesion in the brain MRI is very small compared to the first time of in 2020. And the patient still have the KBS 90 to 100 and no neurologic symptom and the systemic disease control. And he had a left hip replacement surgery in 2022. That's why the reason why he had no MRI between 2022 and 2023 here. We continue with the second case. The second case is a female patient, 43 years old, no medical history and no family history of cancer. In 2019, she was diagnosed with breast cancer, PT32 and N2 and M0. The breast carcinoma BRAF3, ER/BR negative, and HER2 positive, KI 67, 30%. She was treated with mastectomy, chemotherapy, ACT, cycle, and chest wall and regional node radiation, 45.56 grade in 16 fraction. And she continued follow up. And in 2022, she had a recurrent in lung, and she continued was treated with chemotherapy, paclitaxel, caprolactin, a cycle. And in 2024, she recurrent in liver and bone and continued chemotherapy with vinoramine, cabazitaxel, 4 cycle, and continue follow-up. In 2024, she has a headache, and on the brain MRI, she has 2 lesions, and at that time, the GPA is 23.5 months, the KPS 90 to 100. So at that time, we choose the treatment for her is SRS 27 Ray in 3 fraction from 25 October to 27 October in 2023. The GTV1 is the biggest tumor with 21 cc, and the BTV is 31 cc, and the smaller is GTV2 is 0.17 cc, and the BTV is 0.63 cc. And our physicists take the plan with the 4 acts and include a 3-act non-coplanar with the couch 45 degree, 270 degree, and 315 degree. And the max of the plan is 35 rate, about 106%, and the minimum is 27 rate. As you can see here, 100% dose cover 100% ETV volume, and the hit bond is concentrated in the center of GTV. And the normal brand, we accept the dose 20.9 cc is 20.4 gray, and the D7 cc is 23.8 gray. And after after 1 week and 1 month after treatment, the patient totally fine and have no logical symptom. And we take brain MRI after the treatment 3 months. And as you can see here, this is the biggest tumor, and this is the smaller. But on the MRI, we nearly can see the biggest, and the small is very, very small. So thank you for your attention, my presentation.
So thank you for the presentation. So now we will come to the discussion. On behalf of our team, so you can we can use English, Vietnamese, or Russians, because we have also the interpretations here on our site. We have the Russian interpretation, or whether you have the any comments on you can speak in Vietnamese.
Unfortunately, we are not prepared, and for this moment, we do not speak Vietnamese. Still, give us a month, and we will do it.
Yes, but on our side, if there's some people who speak Vietnamese, yes, please. If you try to speak English, it's okay, but the Vietnamese is acceptable here. So yeah, so we start soon about the discussion. So I can see there's a questions here. So I don't know whether any.
So we have 2 questions in the chart. Yes.
Yes.
Okay.
So to answer the question on the chat box first. So when working on the image registration between MRI and also the simulated CT scan, what landmarks that we will base on to make sure that we can make an accuracy contouring on the CT scan especially when the tumor is very small. So on our side first. So any comments from Dr. Xuân, Dr. Quỳnh Anh, Dr. Mai, and also the radiation oncologist online?
На что ориентироваться, когда маленький отчет?
First of all, thank you for your presentation. It was very interesting. Your experience is very interesting, and I also have several questions, but I have also, for the first question, the size I have told, it was 4 centimeters. What about the very small lesions? It's a problem. We irradiate the metastasis from 1 centimeter and no larger than 4 centimeters. We have CyberKnife, not in our center, but the centers that near us, and Gamma Knife, and so we prefer to send patients with very small lesions here. But for 1 centimeter lesions, we would like to irradiate. We can irradiate them when they near bones, and so we can provide the quality assurance with bone fusion, but not smaller than 1 centimeters. And I would like to ask you, do you prefer fractionated radiosurgery or one single? Do you use one single radiosurgery treatment, or one fraction, single fraction radiosurgery?
Xin mời chị Xuân ạ. Chị Xuân có cho thêm ý kiến cũng như là cái câu hỏi của bà bác sĩ trưởng khoa bên đấy, bác sĩ trưởng khoa bên trưởng khoa xạ trị của San Vistor. Dạ, xin mời.
Your question for that question, for one lesion, we just do one fraction for lesion less than 2 centimeter, from 1 to 2 centimeter, and for 1 centimeter you use 20 to 24 gray, and larger than we use 18 to 20 gray for that.
Thank you. And do you use any landmarks for small lesions when you use the MRI and the simulated CT scans?
We just use the fusion, CT and MRI for just the landmark, the bone scan, eyeball, and brainstem for many landmarks on MRI and CT scan we use to fusion.
Do you use any landmarks?
Landmarks.
Yeah, you can give the example, Dr. Xuân. You can give the example any landmark on about these small lesions you use to draw the concern.
No, we of course we don't wait while the lesion become more larger. If the lesion is asymptomatic, we ask our chemotherapist to help us and to give the patient the systemic therapy.
Yes, so the main question for now, in terms of at least breast cancer and lung cancer, is the sequence of radiotherapy for lung metastasis and the sequence with chemotherapy, targeted therapy, or immunotherapy. So And this question is very high. I think, as I know, in Asian countries and in Vietnam, also there is a high frequency of patients with activating mutations, at least with the GFR mutation. So how do you sequence targeted therapy with your brain-directed radio surgical procedures?
Chị Xuân ơi, chị Xuân có thể trả lời câu hỏi được không ạ? Cái câu hỏi của mình là, thank you.
For lung cancer, we use SRS for non-mutation patients. And when they have a mutation in EGFR, we just use the targeted therapy first. After that, if they have progression, we
Okay, thank
after
you.
that we use the SRS.
Do you use consolidation radiotherapy on the residual lesions, at least in brain, after you achieve success with targeted therapy on brain disease, or no? Do you consolidate the efficacy, the response you achieve?
Dr. Chung, so the question is, yes, if the lung cancer patient receive, for example, systemic therapy with TKI like osimertinib, and they have a really response, and then not this complete response, but just the partial response, and there's the RD, mean that residual disease on the brain. Do you indicate the radiation for the residual lesions or not? Thank you.
For that case, if the patient have no symptom, I think that they can continue to use the TKIs, not use SRS.
Okay, and what about whole brain irradiation for multiply metastasis? Do you employ this kind of treatment? Whole brain irradiation.
Yeah, I also think that that is the questions here, because you can see that for the limited brain mass like in Russia's, in St. Petersburg, you choose the number of lesions is 10, less than 10, but actually in here, in our hospital, we choose is 4. So it's not only the number of lesions, but also the volume of the lesion as well, and also for the blending for the radiation volume. So what do you think about the differences between St. Petersburg Center and also Ho Chi Minh City Oncology Hospital? Yeah, this is my question for both teams. Thank you. For the whole brain radiation. Also here we have also hypothalamus avoidance whole brain radiation as well. So Dr. Sung and our teams here, Dr. Winan, Dr. Mai, also could you give some aspect about our whole brain radiation technique here to preserve the cognitive function of the patient? Thank you.
For patients use the whole brain radiation therapy. For nowadays, we just use the technique preservation hypothalamus. That's it. We use a little indication for that, because for the technique and for the many patients for use the technique, and we can use if we have the home brand indication. It's not good to use that technique, because we have a little experience about that. And I have a question for you. Should we share the experience to do SRS for the multiple lesion brain mass? we don't have experience about how many lesion and how many millimeter do you use SRS for multiple lesion?
We employ radiosurgery for no more than 5 metastases, and we also see the total volume of these metastases. And sometimes when there is the ability to give the systemic therapy for patients with multiple lesions, small lesions, we irradiate only symptomatic, more large lesions and avoid whole brain irradiation. I think that the treatment of patients with brain metastasis must be personalized according to the radiosensitivity and chemosensitivity and targeted therapy.
Yeah, I think that this is also appropriate approach about when we have the multiple lesion like this, but this is so small. So to increase the quality of life of the patient, and also to control the disease, we can use the alternative between also the combination between the systemic therapy and also for the SRS for bigger lesions to control the lesions as well. And here in Ho Chi Minh City, we think that is the lung cancer. We test for the EGFR mutation, ROS1 and AOK as well. If the patient don't have any drivers or mutation like this, we also give the patient the chemotherapy and also the immunotherapy as well. And for the cases with the HER2 positive breast cancer, you can see that this is a very strange case, but I think that the patient is so poor to receive the anti-HER2 therapy. Here in Ho Chi Minh City, we have the anti-HER2 therapy like trastuzumab, bevacizumab, TDM1, and also now recently we have the trastuzumab deruxtecan. And for the brain met HER2 positive breast cancer, we also indicate the combination of tucatinib, trastuzumab as well. So we have all kind of systemic modality, almost all kind of systemic modality in Ho Chi Minh City to give the patient the benefit of not only brain control, brain lesion control, but also for all the places, systemic control as well. So please don't forget about the systemic disease. Don't not only focus on the brain met. So that's my comment about the alternative of the systemic therapy and also for the radiation for the kind of patient. So there's one question for the both teams. So you can see that after the SRS, or you can see the gamma knife or cyber knife, the patient usually have the necrosis, and sometimes it's delayed necrosis, and so this could spread out, and it could cause the symptom for the patient. So usually, do you consult a neurosurgeon to resolve the problem for the patient or not? Thank you.
Это же не был вопрос, да?
Yes, it's true. We have the neurosurgery department, and the collaboration with these guys is very important to determine the optimal approach for every particular patient. Still, our decision primarily is based on the first, the urgency. So if the appearance of the lesion unfortunately to have the clinical symptoms and is dangerous for the patient, so then we proceed to neurosurgery, at least for the dangerous lesion. So if another thing when we choose surgery is when the size of the lesion is too big for radiosurgery. So all the rest of our patients, we try to treat them conservatively, and to provide them with radiotherapy because we think that for metastatic patient, systemic control with either type of drug therapy is of the primary importance.
And I could like to have another question for you. So, for the brain met patient in San Petersburg and also in Brussels as well, do you practice intrathecal chemotherapy or systemic therapy? Sorry, for targeted therapy for intrathecal. Do you practice so? Yes.
We've done it only several times for patients with, for example, testicle B-cell lymphoma for the prophylactic of cranial involvement. And we've done it, I think, once or twice, probably. And so we do not often use this technique.
Okay, thank you. So any question and any comments from the participants from both sides? Yes.
I have two last questions. Do you use spinal cranial irradiation for leptomeningeal dissemination? We have two patients with spinal cranial irradiation with a good result, but with hematological toxicity. Do you have the experience of irradiation of the spine and cranial for leptomeningeal disseminations? The first question, and the second for patients with small lung cancer. Do you employ prophylactic cranial radiation or MRI control?
So for the first question, Dr. Chung, could you answer for the radiation of the leptomeningeal metastasis or not? And the second question, I didn't catch you, Dr. Sarabura. So after the first question, please repeat the second question for us. Thank you. So Dr. Chung and Dr. Wundan, do you have any comments on the radiation? Yeah. Xin mời chị Xuân ạ. Wundan chuyển cho chị Xuân.
Today we just use the spinal radiation for some patients for children, but for leptomeningeal we not use yet.
Do you have any experience on the radiation for the leptomeningeal metastasis or the primary tumor of the leptomeningeal tumor as well? Dr. Sarabura, do you have any comments?
Yes, we have the very small experience, but the hematological toxicity was very large, but we continue the irradiation with symptomatic relief.
Yes, I think so, because there are some primary tumor of the leptomeningeal. Yes, we can radiate them, but actually for the other reason like leptomeningeal carcinomatosis, is very hard for us to control the progression of the tumor. So I think the systemic therapy and sometimes intrathecal for some cases like Dr. Chung already mentioned that possible for the childhood cancer is possible to give the radiation, but not for the other cases like the Andon's solid tumor. Do you agree so?
Yes.
Yeah, and your question, your second question, I didn't catch you up.
For small lung cancer, do you employ whole brain radiation, prophylactic cranial radiation, or you prefer MRI control?
You mean not the small cell, right?
Small
cell lung cancer, right?
Small lung cancer, that's
small. Yeah, small cell. So Dr. Chung, Dr. Wundan, and Dr. Han, could you answer this? Yes.
Yes, we do the prophylactic brain radiation for the small cell lung cancer. If after their chemotherapy, if they have good response for the chemotherapy.
Good response for the primary tumor of the lung. You have the response, a complete response, right? After that, you have the surgery or radiation to the primary tumor, and after that, you have the radiation for the brain.
Maybe after the induction chemotherapy, and we can radiate the tumor of the lung and the prophylactic radiation for the brain.
So I think that we have the same situation in Ho Chi Minh City Oncology Hospital. We have the small cell lung cancer. If you can give the patient the chemo radiation, after that you have the complete response of the primary tumor. And if the patient has a high risk, then the prognosis is very good. For example, for the young age patient, we can give the patient with the brain prophylaxis radiation. And then I think that is the same doses in like in your practice. So I think that we have a very fruitful discussion, and also for the for today's topic. Do you have any question or comments on today's practice? To today's topic?
No, we don't have any questions. Thank you. I think that it was very interesting discussion, and may suggest you for the next meeting the discussion of the predictive role of PET-CT for the effectiveness of chemoirradiation of lung cancer and maybe head and neck cancer.
Head and neck cancer. So I mentioned to Ms. Anastasia that possible for the next topic is irradiation for the pelvic tumor, right? Pelvic tumor like cervical cancer or rectal cancer. So which one do you want to discuss?
Okay. Let it be the second radiation of the
rectal cancer, right? Rectal, or you want to rectal or cervical cancer? Because I think the cervical cancer is more important cancer in Vietnam. And you have the brachytherapy here, and also for the radiation. So the patient with the relapse, we also give the patient the irradiation very often. But do you think that this is the suitable topic, or you want to another topic? Please let me know.
No, let it be the second radiation of the second tumors or recurrence of this tumors of the rectum or cervical cancer. Yes.
Yeah, so thank you.
Он просит просто одно выбрать, цервикальный или колоректальный?
Any.
Какой?
Yeah. So we will.
Any you prefer, Dr. Pan?
Yeah, and any suggestion from you also. So I think that for the topic today is fine now, but we have one or two more things to discuss about. The first thing is for the next the several months topic. We could exchange later with Anastasia, or Anastasia, could you give the recommendation in our group, not only you and me, right? Because it's hard for me to follow up all the time on the WhatsApp. So sometimes I drop out, sometimes I miss the message from you. So please SMS on the big group on WhatsApp as well. Second thing about the exchange of the internship or doctors from St. Petersburg institution and Ho Chi Minh City Oncology Hospital. What is your recommendation? There's one thing that is very hard for us. send out our doctors, our candidate to San Petersburg right now because you are very near the war zone. So many doctors are very afraid of flying to San Petersburg. So, frankly speaking, I have to say that because when I recommend some doctor to go to San Petersburg Cancer Institution right now, they refuse. But actually, we could receive your candidate as well. So, Dr. Sarabura, you mentioned to me to us before that you could like to come or you will send your candidate to come to our.
Yes, we have one candidate from the radiotherapy department, from
Yes.
Dr. Sharabura's department. So this is the Dr. Polina Brukhunova. She is always with us on these conferences. So we can send you her CV, and if you will agree and confirm her, we can send her to Ho Chi Minh. I may mention that we will send another doctor from another department to the Medical University Hospital of Ho Chi Minh.
Yes.
She will come in July.
Okay.
And so if you can agree that we would like to send both to Ho Chi Minh so they can have support from each other during the internship in Vietnam.
Yes, of course. We were very honored to receive your doctors and your also not only doctor but also could be nurses, physician or any membership team members from your team could join us. In Ho Chi Minh City, we are very well known about the reconstruction surgery, the head neck surgery, and also for